Welcome to the next in our series of Oticon seminars, and we're grateful to Oticon who sponsor these weekly events. This week our presenter is Dr. Piers Dawes, who most of you will know because he's a lecturer in our group. One of Piers' interests is looking at population-based data, so getting big numbers of the UK population and looking at things like what is the hearing level according to age? Is there a relationship between wearing a hearing aid and your cognitive ability? Is there a relationship between the amount of alcohol you drink or the food you eat and your hearing ability? So Piers has been engrossed in this sort of work for the last year or so and has plans for extending this work. One particular question he's interested in is, does hearing loss lead to dementia? And there's a lot in the press right now about this sort of issue that dementia is increasing. It's a huge burden to society, and yet we know that if you have a visual impairment or a hearing impairment, you're likely to have poorer cognitive ability. And the question that's really important is, and that Piers might tell us a bit more about today, is if we were to prevent or provide intervention for a visual impairment, a hearing impairment, could that change the cognitive decline? Or is it something that's going to happen to us as we get older anyway? So quite an important question, and that's what Piers is going to be talking about today. Thank you.
Okay, thanks very much, Kevin. So, why are we bothered about dementia? Dementia is quite a nasty condition. It involves memory loss, mood changes, problems with communication and reasoning, and disorientation. And it's associated with age, and previously people thought it's just something that tends to happen as you get older. But now it's more viewed as not necessarily a consequence of natural aging, but maybe associated with pathological processes. It's quite a common condition, tends to be associated with age. So in people aged 40 to 64, it's relatively rare, less than 1 in 1,000 people. But by the time we get to over 69-year-olds, it's already 1 in 100. 70s to 79, 1 in 25. And over the age of 80 years, 1 in 6 people will have dementia. This graph shows the population structure of Europe, including the UK. And the ghostly bars, the ones that are not filled in, shows the population structure in 2011. And the solid bars show what the projected profile of the population is by age group in 2060. And you can see in 2011, there's relatively more younger people to older people. But by 2060, there's quite a different population structure. And the same thing tends to happen in all industrialized countries. You can see there's a relatively higher proportion of older people. There's a particular spike in that top 85-year-old age group. That's because it includes everyone aged 85 or older. And that's larger for women than men, because women tend to live longer than men. But what this means is, by 2060, nearly a third of the population is going to be aged over 65. And especially for this older age group, very old people aged over 80, we're looking at a 3-fold increase in those numbers of people. And because dementia is particularly associated with age, this means that we're confronted with a kind of epidemic of dementia, large numbers of people. So in 2012, estimated that there'd be about 800,000 people in the UK with dementia. By 2021, this expected to have grown to about 1 million people. And by 2051, it's just under 2 million people with dementia. So that's some pretty frightening statistics.
Can we ask questions now?
No. I prefer if you wait till the end. Yeah.
Okay.
But I was going to make a comment, and that is,
sure.
by 2051, that's when the individuals who are students here are going to be in their mid-60s to 70s, so they are the prime people
Right.
on this blue part of your
Yeah,
graph.
so this is something that we need to worry about. Okay, so dementia is obviously quite bad. It has a profound impact on not just the individual, but also the person's family. It's a progressive, degenerative condition, and currently there's no cure. Most of the treatments are centered around managing the unpleasant symptoms that come with dementia. Although there's no cure, this treatment's really expensive. It's estimated it costs £23 billion a year in the UK to care for people with dementia, and £8 billion in social care, which is the cost of care provided by family and friends. So wouldn't it be great if we could reduce the numbers of people getting dementia? It'd be great if we could cure dementia outright, but can't do this at the minute. But even if you could just delay the onset of dementia, this would result in a huge reduction in the numbers of people with dementia. So here's a study that modeled what would be the effect if you could delay dementia by 2 years. You'd reduce the numbers of people with dementia by 13%. If you could delay the onset of dementia by 5 years, that would reduce numbers of dementia by 1/3. And there's some reason to be optimistic that it might be possible to at least delay and prevent a lot of cases of dementia. So a couple of studies here, a recent one by Matthews and colleagues in the UK. They surveyed prevalence of dementia in UK adults in the early 90s, and they repeated the survey using the same methods, same sampling strategy, like 20 years later. And they found there'd been a significant reduction in the prevalence of dementia. And they thought this might be because the younger generation had been through different life experiences which meant that they were less susceptible to develop dementia. And that if you could identify what are the important life experiences, maybe you could kind of boost those life experiences to mean that fewer people are likely to develop dementia. And we have a rough idea of what the sort of experiences that might be important are. There's another review on this slide by the American National Institutes of Health. And they reviewed a bunch of studies. Most of them are fairly low quality, but there's some evidence that lifestyle-related things like diabetes, high cholesterol levels, and smoking are associated with increased risks of dementia, while having a healthy diet, drinking moderate amounts of alcohol, and remaining cognitively and physically active are all associated with reduced risk of dementia. And they concluded that this is quite promising, suggestive data, and that there's an urgent need to more research into the possibility of preventing dementia. So we're interested in the idea that maybe treating hearing loss could be something that could reduce the prevalence of dementia. So why do we think this might be possible? So there have been numerous studies over several decades that have showed that sensory losses are strongly associated with cognitive decline. So here's quite a famous couple by Lindenberger and Voltes. They were the investigators on the Berlin study of aging. And these are data from their 1997 paper with a bunch of people, young to old. They did a battery of intelligence tests and assessed their vision and hearing acuity. And you can see in these figures here there's quite a strong association between hearing, vision, cognitive performance, and age. So that the correlation between sensory function and intellectual ability is pretty high, 94.7%. And if you factor out age, they're still associated, 12.6%. So for any given age, the amount of variance in sensory ability has predictive power for a person's cognitive ability. That makes sense. Here's another study by Frank Lin and colleagues. I think this is data from the Baltimore longitudinal study of aging. And they took a bunch of people who had no dementia in 1990, and they followed them over 11 years, tested their hearing at baseline in 1990, and looked at which people developed dementia over those following 11 years. And this graph shows the risk of developing dementia according to the person's level of hearing loss. So as you can see, as the level of hearing loss increases, so does the risk of developing dementia over those 11 years. So we have these observations that hearing loss is associated with cognitive decline, and it's associated with an increased risk of dementia. But we don't know whether this association is due to a common cause. For example, maybe there are vascular or neural changes that affect both cognition and sensory performance independently. Or could it be that there's a role for auditory sensory deprivation? So the idea is there's a sensory deprivation or imbalance in sensory input. This could impact on cognition either directly or via effects of social isolation or depression. So if a person has hearing loss, they find it more difficult to engage with people, they tend to withdraw, they may get depressed, and this could impact on their cognitive performance via lack of stimulation, for example. So we're interested in the idea that if this deprivation hypothesis is true, that sensory deprivation contributes to cognitive decline and dementia, if you could reduce this deprivation somehow, for example by providing hearing aids, could this have the effect of slowing cognitive decline and preventing dementia? So we've looked at this in a couple of studies so far, and I'll go through them with you now. The first is a study with a UK data set where we've looked at associations between hearing aid use and cognition in a cross-sectional analysis. And the second is using an American couple of data sets, epidemiology of hearing loss and the Beaver Dam offspring study, where we compared cognitive performance longitudinally in hearing aid users versus non-users. Let's talk about that first UK study first. This is where we're interested in modelling associations between hearing and cognition in a very large UK biobank data set. This is a resource that's set up to conduct epidemiological research into all sorts of different diseases. And we're interested to see if there's an association between poor hearing and poor cognitive performance, and if there was, that could be consistent with either a common cause or a deprivation hypothesis. But if there's an effect of auditory deprivation on cognitive decline, then we expected that for equivalent levels of hearing loss, people who use hearing aids should have better cognitive performance. And we were also interested to see if that effect might be due to the effect of hearing aids in reducing social isolation or reducing depression. So the participants were 164,000 people, a very large subset of the UK biobank. These are all the people that did the hearing test, which was a speech and noise recognition measure. They also did a battery of cognitive tests, a reaction time, fluid IQ, and a pairs matching memory task. They were asked if they used a hearing aid most of the time, and they were asked if they felt lonely, and they were asked about the number of social activities they took part in. And they were also asked about depressive symptoms, how often they feel depressed, and how often they feel like they have little interest in things. And we used a statistical modelling technique called structural equation modelling. And this is a way of testing and modelling causal relationships. So is hearing aid use associated with better cognition, and is this mediated by social isolation, for example? It's a way of testing whether that set of relationships is plausible given a set of data that you have. So it involves constructing a hypothesis, imagining how these different variables might be related to each other according to your hypothesis, and then testing to see whether the data fit your model, whether they're plausible. And it's a technique that is a bit like regression, but you can use it to test more elaborate models. So we tested the association between hearing loss and cognition. Is it mediated by hearing aid use, social isolation, or depression? And we controlled for possible confounding effects of age, sex, general health, and socioeconomic status. So this is the set of models that we developed, and you can see they get more and more complicated as we've included different variables into the model. And you can see that these models have an advantage over regression. This top case here is similar to a regression, quite a simple model, but these ones show a more elaborate set of relationships, and that's the advantage of using this structural equation modeling technique. I'm not going to go into these models in detail, but here's a summary of the final one. So it shows that hearing loss was significantly associated with hearing aid use, unsurprisingly. It was associated with social isolation, depression, and poorer cognition. Social isolation and depression were quite strongly associated with poorer cognitive performance, and that's been a well-observed previous finding. And interestingly, people who used hearing aids did tend to have better cognitive performance. But there was no association between hearing aid use and social isolation and depression. So the conclusions is that it is plausible that hearing aid use may improve cognitive function and may protect against cognitive decline. But they do so not via effects on social isolation or depression. The limitation with this study is it's just a correlational study, so we can't say for sure that hearing aids had a causal impact on cognition. And for example, it might be the case that people with better cognitive ability tend to be the ones that choose hearing aids, for example. So that led to the second study, which I did while I was at the University of Wisconsin in Madison, and that was funded by a Fulbright scholarship and Action on Hearing Loss. I'll just take a minute to describe that. The Fulbright organization is a body that seeks to promote exchange between the US and the UK, and they have scholarships for lecturers and professors, as well as graduate and undergraduate students to go and study in the US, and it was a really great experience. So I encourage you, if you're interested in experiencing life in the US and building collaborative relationships, which have been really helpful in my case, then have a look at the Fulbright program. Great. And that's Bucky Badger in the middle. That's the university mascot. And that building on the right is where I had my office with a great view of the lake outside. So the idea in this study was looking at the long-term outcomes associated with hearing aid use. So we took a bunch of people that had hearing loss and compared their cognitive performance in the long term, comparing people who used hearing aids to those who didn't have hearing aids. And we thought if they're consistent with the deprivation hypothesis, hearing aid users should have better cognition lower prevalence of dementia, fewer concerns about their cognitive performance. We had two longitudinal cohorts, the epidemiology of hearing loss study, which is one of the world-famous epidemiology of hearing loss study. It's been running for over 25 years. Professor Karen Cruikshanks is the head of that study. That's an older sample of people. And we also have the Beaver Dam Offspring Study, the BOSS study. And these are the adult children of the people in the epidemiology of hearing loss study. And they were a younger sample of people. They haven't been going for quite as long. I think they have data over about 15 years for that sample, but still quite a long time. So we selected a subset of these two samples if they had hearing loss, all the people that had hearing loss at baseline, which is defined as a threshold worse than 40 dB in the better ear over 3 and 4 kilohertz. And we compared hearing aid users with non-users, controlling for potential confounding factors such as age, level of hearing loss, education level, income. Okay, here's the design of the study. I'm not going into the BOSS cohort on the right, but the epidemiology of the hearing loss sample. There were 4 data collection time points separated by about 5 years each. At the pre-baseline, all the people with hearing loss, about 666 people, at this time point, none of them used hearing aids, even though they all had hearing loss. At the second time point, the baseline, 69 people had obtained hearing aids, the remainder were still non-hearing aid users. And if we look back at this pre-baseline, there are no differences between the hearing aid users and non-users in terms of age, sex, cognitive performance, education level, income, but the hearing aid users tend to have a slightly poorer level of hearing loss. They were then followed over the next 11 years with 2 time points, the 5-year outcomes and the 11-year outcomes. And you can see there are fewer people at each time point, and that's because some of them have died off. Oh yeah, that box just says what I already told you. They performed a battery of cognitive measures. The asterisk there shows the measures that were only performed at the 5-year time point, and at the 11-year time point they did all of this test battery. Mini mental state, which is a screening test for dementia and a marker used to identify cognitive impairment. Trail making test, which is a speed of processing and executive function test. Digit symbol substitution, which is a test of memory, speed of processing. Auditory verbal learning test, where you have to learn a list of words and recall them, so a test of learning and memory. Verbal fluency test, which is kind of like a recall fluency test, so you have to name all the things you can think of beginning with the letter A within 60 seconds. And whether you, your family, your doctor has any concerns about your memory, whether you think memory loss interferes with your daily life, and whether you have been diagnosed with Alzheimer's disease by a doctor. And here's the outcomes at the 5-year and the 11-year examination time point. And the p-values there are the p-value for the group comparison adjusted to take into account various possible confounding factors, such as the level of hearing loss, age, income. And you can see at the 5-year examination there's no difference in many mental state score. There's a couple of non-hearing aid users who've been diagnosed with Alzheimer's disease, nobody in the hearing aid user group, but that's hard to say. It's a pretty small proportion in the non-user group. At the 11-year time point, no differences between the hearing aid user and the non-user group in any of those measures. you can see a couple of measures are kind of borderline statistical significance, mini mental state and the AVLT verbal learning test. But there, the direction of the difference is actually better for the non-hearing aid users. So that's the opposite direction of what we'd hoped to see. So we have a couple of kind of conflicting evidence from these two studies. Study 1, hearing aid users had better performance, and that supported a possible positive impact of hearing aids in improving cognition. But in study 2, in this longitudinal study, there were no differences in cognitive performance over time. And this doesn't really support a strong effect in hearing aid users being protective against cognitive decline. So why do we have that discrepancy? A few differences between the study. The US data sets, that refers to an older sample, although we also have that BOSS data set, which I didn't talk about. Findings in the BOSS data set were the same as for the epidemiology of hearing loss. And the BOSS sample is a similar age to the UK Biobank. There's a different system for hearing aid provision in the US in that you have to pay for them. The hearing aids are really expensive, so we thought that would have had an effect on the results. But if there was an effect, you would have thought that should result in better hearing aid, better cognitive performance for the hearing aid users as they're richer, more affluent people. The US data sets are much smaller than the UK Biobank, so perhaps there's a power issue. Perhaps we just didn't have the power to detect an effect. But if there is an effect, it's probably pretty small if we couldn't see it in that sample. On balance, I think I'd be more likely to believe the findings of study 2, the longitudinal one, because that's a stronger longitudinal cohort kind of design. So where do we go in the future now? Well, we're planning a similar kind of longitudinal follow-up of the UK Biobank data set, seeing what happens to hearing aid users versus non-users, and a reassessment time point 5 years from the original assessment. See if hearing aids are protective against cognitive decline in the UK data set. And we're also hoping to conduct a randomized controlled trial of the effect of treating hearing loss with hearing aids on cognitive performance. And that would be a kind of gold standard experiment. Just a final thought then. So dementia is diagnosed when the cognitive impairment is severe enough to cause major disability and impact on somebody's ability to function in their daily life. Hearing loss might exacerbate these sort of difficulties. You can imagine it, especially if somebody has a cognitive decline, hearing loss is just going to make their disability even worse. Pharmacological interventions for dementia are mostly aimed at reducing the impairment by slowing or reversing the underlying pathology. But maybe hearing aids could be helpful in a different way. They reduce disability. They might actually delay the point at which dementia would be diagnosed. So it could be the case that hearing aids, they might not actually prevent the underlying brain pathology, but they might reduce the prevalence of dementia and improve quality of life in older people. So that would be quite an important and useful finding if that's the case. And that's what we're hoping to investigate in the future. Lastly, I'd like to thank the collaborators on this research, Manchester, Kevin Monroe, Richard Elmsley, biostatistician who did the structural equation modelling, collaborators in Nottingham, Dave Moore in Cincinnati, and people at Wisconsin University, Karen Cruikshanks. Okay, thanks very much.
Thanks, Piers. Has your question been answered, Karen? Do you still have that question?
In principle, yes, because I was interested in those predictions you know, what is the proportion of people with dementia in 2000 and whatever. And I was just going to say that what you showed a moment later, that we know that things change all the time, and generations are, you know, present so differently. And I know that people say, well, I don't know, 70 is the new 50, but it actually is, you know, that you can't compare a 70-year-old at the moment and, let's say, some generations ago. And I think it will change in the future as well.
Although it may not change for the better in the future. In these two generations, we saw a reduction in the prevalence of dementia. But people are worrying now that young people today have this problem with obesity and overeating. There's an epidemic of obesity that people talk about. And people are really worried that this is going to have knock-on effects when the young people of today become older. So at the minute we've seen decreasing rates of dementia, cardiovascular disease, all these sorts of things. But that they may not continue to decline in the future.
Have you seen a really old fat person ever?
Good point.
There you go.
Yeah.
With your stuff, you said delaying dementia by 2 years would reduce it by 30%. By 33. Is that assuming that life expectancy stays the same? Just more people are dying before they have dementia? Or is life expectancy factored into that?
I'm not sure about that detail.
Because surely if you've got people getting it later, but life expectancy is still the same, then they're dying before they get dementia. I would assume that they would have taken into account the projected increases in lifespan in those estimates. Yeah, you can check out the references given for that modelling down below there.
It's regarding the using hearing aids and not using. Is it just an information that their users they've been, you know, don't you think that the hours and frequent the hours of wearing the hearing aid and situation, everything might be the difference and that detecting.
That could be an important thing, because some people, they might be very part-time users of hearing aids, and in that case, you wouldn't think hearing aids could have much of an impact. In the UK Biobank study, people responded to the question, do you wear hearing aids most of the time? And in the Beaver Dam studies, they actually had fairly detailed statistics on people's daily use of hearing aids, which was quite high on average. And we kicked out any people that reported they only wear their hearing aids occasionally. So the hearing aid users there were quite regular users. Good question.
Thanks, Piers. I was interested in your plans for the future, where you're talking about testing for use of hearing aids leading to reduced dementia and improved quality of life. But many people perhaps might associate using hearing aids itself with a reduced quality of life. Perhaps the stigma of using a hearing aid, and that in itself is a sign of aging, and might suggest that actually wearing hearing aids would be a more of a reduction than the dementia, and that might affect the way in which you approach that question.
Yeah, that's an interesting point. Yeah, so I didn't mention, but in the Beaver Dam studies, we weren't just interested in cognition as an outcome related to hearing aid use, but we looked at a bunch of other stuff. So people have also suggested that hearing aids might result in better mental health, so less depression. They might result in better general physical health. If you can hear better, you're more engaged, and maybe you can take more charge of your own health, that sort of thing. So we looked at a whole range of other outcome measures, and the hearing aid use was associated with slightly better physical health in the long term. But in the process of doing the study, I reviewed other literature, most of which on the impact of hearing aid use on various outcomes. Most of these studies are not very good quality, but there was one study where they just did a before and after measure of the effect of hearing aid use on self-perceived physical health and mental health. And they found that in the hearing aid group, the hearing aid users, there was a reduction in self-reported physical health. And that was kind of contrary to what the authors were expecting. And they explained it in terms of, now if people had this hearing aid, it kind of made them feel old and more decrepit and less healthy. So I think that kind of relates to the point that you're making. Yeah. And yeah, I think there is a problem with the stigma of hearing aid use.
So one of the points he mentioned, Piers, is on the cross-sectional data from the UK. The hearing aid users have better cognitive ability, and it may just be that they were brighter to start with.
Yeah.
And it motivated them to go, I better go and get a hearing aid because I'm going to be in trouble.
Yeah.
But on your longitudinal one from the States, there was no difference in cognitive ability at the beginning, right? So that doesn't kind of support this possible argument to explain the UK finding.
No, that's true.
So any more thoughts about why we might have got that difference then? I mean, so you were saying that the longitudinal study is the one you'd attach more importance to.
Yeah.
But all the same, we've got this cross-sectional stuff that say hearing aid users have better cognitive ability. Your longitudinal one said, at least from the States, they weren't different to start with.
All right. One possible explanation for that UK biobank finding was that, well, we don't know what people's cognitive performance was like before they had their hearing aids. So it might be that similar to the American study, there was no difference. But since they've got their hearing aids, cognitive performance has improved. And it might be that the hearing aids have had a positive impact on people's cognitive performance. One explanation that we thought of is that maybe hearing aids just make you feel more self-confident. So there is some research to say that hearing loss is associated with a reduced kind of self-belief. You know, if you can't hear properly, it makes you feel less competent, less able. And this feeling of low self-efficacy is associated with reduced performance on cognitive tests, for example. So it might be the people with hearing aids did better on the cognitive tests. It's because they felt more self-confident. So that's why they did better on the cognitive tests. Unfortunately, we didn't have any measures of self-efficacy in that study, so we can't see if that explanation makes sense or not. But that's a possible explanation.
So if we're wrapped up with questions, thank you for coming along today. Thank you to Oticon for sponsoring these events. Do we know who's speaking at the seminar next week? This is Piers coordinates these things.
Anyone remember? It's embarrassing that I can't remember.
Well, we do have one. Same place next week at 1 o'clock. And thank you to Piers for his presentation.